Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another episode. Today I'm with Dr. Roger Levin with Levin Group. We've had a series now going here. We've had some great feedback on the content that you've been sharing, Roger, so thank you for joining us again to share more information.
Oh, Grant, I love this. We've done enough of these that I know we're helping a lot of people, which is great. And, practice is so challenging. Anything you and I can do to shorten the curve for success for, your colleagues and surgeons is absolutely my pleasure. I love these podcasts.
Oh, I do too. Yeah, and I appreciate you sharing so much of your experience and content. For free. We were just talking about this earlier, but I try to share all my tricks and tips of, a lot of clinical stuff that I do oral surgically. And if anything, it always comes back to me in spades. I always get people sharing because I feel like that opens the floodgates when you are a little more vulnerable and share what you're going through, then other people will share and it just kind of snowballs and we all learn together. So it's a good thing.
Yeah. Well, it's interesting, a couple things I've seen in my career. I do a lot of speaking, as you know. In fact, next week I'm in New York and California. And sometimes they'll call me and say, are we allowed to record your seminars? And my answer is, of course. My attitude is anything I say publicly can go anywhere anybody wants it, because I just want to make a difference and help people. And the other thing is, when you share, you get so much back. That's sure. The beautiful thing. You put things out there, it comes back. You often learn from others in a great way. You get real life experience, which allows us to make our work and our programs and our education even better.
Yeah, I totally agree.
Yeah.
There's different opinions about that, of course. I mean, I've had surgeons, before a podcast tell me, I'll share just generally what I think about the profession, but I won't share details of like how to trough around a tooth or section the tooth because that, is proprietary and you need to go through residency to experience that. And then others, just share everything. So I'm not entirely sure what the right answer is, if there's a right answer, but I've always been on the end of just sharing everything I've got because I feel like I said, others will share, and I've learned so much. My practice really, honestly, has evolved just because of the info from the podcast, and I feel like I'm safer now. I work better. It's better for my patients, so it's a great thing.
Yeah, I filter most philosophical questions like this by asking a question. If you're Coca-Cola and you give away your secret formula, then you've got, 5,000 competitors overnight. So the question that I've asked myself in general is, if someone shares something, will it hurt them? Are they going to be hurt by teaching something to others? And in my case, I can't think of anything I've ever shared of the work I do that would have hurt me or my company, Levin Group. So I just have a total transparent attitude of sharing as much as I can. And of course, I have a lifetime mission of making a difference. And you can't make a difference if you're holding back on people. So
for sure.
That's what fits me.
Awesome. Well, we appreciate it. So today we're going to talk about more on the aspect of the implant coordinator of the practice. Can you talk to us a little bit about that?
Yeah, let me put it in context, because you and I have done some really fun podcasts together, and we've done marketing, and we've talked about customer service and leadership, and I hope we'll do more in the future because those are such broad topics. But about 2 years ago, Levin Group made a decision to develop a brand new consulting program. It actually launches September 20th, 2025, called Implant Referral Marketing. And the reason we are launching this is we saw a need. We never launched something just to launch it. We saw a need. And the need is that when implants first started, and you may or may not be aware of this, back in 1985, we saw the first beginnings of osseointegrated implants. And of course, which specialty jumped on this immediately? Oral surgeons. And I joke, but I'm not really joking. We didn't know if they worked. We didn't have great techniques. We didn't have all the information. The list of patients that could not have implants, there were like 25 items: smokers, diabetes. Those were contraindications in the middle 80s for implants. But oral surgeons, being oral surgeons, went ahead and said, okay, we can do this. And I'm so glad they did. And they started placing implants. And by doing that, the general dentists and the prosthodontists had to learn to restore them. And then by the early 90s, the periodontists came in, acting as more competition for the surgeons at that point. And today, it's still, surgeons still place more implants than periodontists, but the ratio's gotten smaller. And you do have general dentists, but here are the facts. 70% of general dentists do not place implants, and 20% place less than 10 a year. So every surgeon should be comfortable that there are very few GPs out there that really want to place all the implants. And those GPs, you often have to clean them up on the mistakes that they make, which is a whole nother subject. So in launching and researching this brand new consulting program, Implant Referral Marketing, we decided that a critical component was to also train an implant treatment coordinator. Many surgical offices have them and many don't. Many have an assistant that doesn't really have the competency to be an implant treatment coordinator. She can be trained, but she's thrown into the role. And our attitude was, well, it's great if we teach people how to get more implant referrals, but if they're not closing the cases, then that's a negative. So today we're going to focus on the ITC, Implant Treatment Coordinator. I encourage every surgeon to have one for the following reasons. Number one, it will save the doctor time. Surgeons don't get significant production or profit by doing implant consults. Number two, and this is fine if someone doesn't want to do it, I'm okay with this, but we often talk to our clients about having no-cost consults, that the first consult can be a no-cost consult as part of a referral marketing process. They don't have to, it's not essential, but it's a very easy access. We'll talk about some of these things. And third, we want to take stress and pressure off the surgeon. Now, surgeons handle stress well, they handle pressure well, which is good and bad. It's good that they handle it well, and it's bad because then they're willing to put up with it. And you can have an easier, more fun, more efficient practice with higher production and profit with a good or great ITC in place. So this is about delegation. Surgeons don't need to be presenting the cases to patients initially. They come in at the end. They give the blessing, as we call it. They give the validation that this is going to be a great case. The patient's going to love it. They need to meet the surgeon. I just reviewed a surgeon's video for a new website they're putting on. It's a client of ours, so he asked me if I'd look at it. And when I looked at it, it's very amateurish. So I called in our marketing people and we all looked at it and we all said, this makes this surgeon look friendly, local, caring. He talks about his family, trustworthy. What more do you want in a video if he went out and spent $100,000? By the way, he made it with an iPhone. And the truth is, it's great in that perspective. It's a bad video production, but it's a great video. And that's what we want. And the other thing the ITC can do, and then I'll stop for a moment, is promote the surgeon. Third-party proof. That we always talk about third-party proof. Reviews are third-party proof. But here you've got a person right in your practice who can talk about how wonderful implants are, the difference they make in a patient's life, and how great and skilled and expert this surgeon is to do the case. So that's a setup for today's conversation, and we will get more practical on some of the steps that the ITC can take.
I like that. So I assume, by having an ITC, um, apart from the PRC, who we've talked about, is that there's enough volume of implants, there's enough importance on implants, and specialized knowledge about the implants that you have to have this separate person, right? You can't make the PRC just do this job.
No, and just to remind our listeners, the PRC is the Professional Relations Coordinator. I encourage everybody, for your own benefit, go back and listen to Grant and Roger's previous podcasts because I hope they're really helpful. And we talked about this marketing person, the PRC, that we created the concept in 1985. And this is also a person who gets the marketing done, gets referrals increased, takes pressure off the doctors. I spoke to a surgeon a couple weeks ago and he said, I really want to do your marketing program, but I am not going to go out there every single day meeting with general dentists. And I said, well, you don't have to. That's not the idea at all. You need to do a little bit. And then I explained how the PRC handles 95% of the marketing. And he said to me, okay, I'm in. Thank God I don't have to do all that. And I get that. He's like 59 years old, and he doesn't want to do all that anymore. And
Yeah.
he's already successful. So the PRC needs 16 to 20 hours per week minimum. Don't cheat on your PRC, or your program will fail. And if that's a 1 and 2 doctor practice, the bigger you get, the more hours you need. The reason I mention that, Grant, is you could have a PRC in a 1 to 2 surgeon practice doing the marketing 16 to 20 hours a week, and she could work around treatment coordinator time as long as patients can get in. One of the things we teach, and the ITC should be watching for, is get your implant consults in within 7 days, if at all possible. I have a belief. There are a few beliefs in our consulting program, which means no data, can't defend it. But one of my beliefs is motivation in life lasts for about a week. And if somebody gets referred for implants and comes in 3 weeks later, they're far away from the general dentist recommendation, the endorsement, the referral. So we try to get them in within 7 days for that consult. And I'll give a tip right now that I was going to bring up later that's so powerful. And remember, Levin Group has a lot of research data. We do national surveys, they're published. If you have referrals from general dentists, 65% of the implant consults referred will come, only 65%. If the general practice will call the specialty practice while the patient is still in the general practice at checkout and make the appointment, 95% will come. There's a 30% increase right there in implant referrals if the GP office calls and makes the appointment for the patient. So that's just an amazing insight that we stumbled upon years ago. We've been tracking it, and it tracks really well. But again, the ITC needs to be on top of this because she's the one who's going to be educating the patients and hopefully referring offices about the best way to work together.
Okay, so it sounds like there's some training that needs to go in there with all the referring front desk staff and people that work there to schedule it while the patient's in their office.
Yeah, I'm giving a seminar in October to a very, very big oral surgeon organization. And my first 90 minutes is on referral marketing for the oral surgeons. But this group also has general dentists. And my second 90 minutes is to the general dentist on how to properly refer to the surgeons, which I call interdisciplinary care, of course. And I'm very excited about it because I get a chance to tell the general dentist how to refer properly, where normally, like Grant, you're very careful what you tell general dentists they have to do if they want to refer to you, because we want to keep them feeling very open and not restricted. But I get to tell them what I really think. So I'm a general dentist, so I can get away with that.
Nice.
Yeah.
All right. So what's the next info we need to know about the ITC?
Okay, so there are 3 sections I'm going to walk us through. And the first section is called Responsibilities of the ITC prior to the implant exam, before any exam takes place. The first one is the very first phone call. Now, the ITC won't be on that call, But I've always said case acceptance begins in the first new patient phone call. And of course, most patients in OMS practices are the new patient. So we've created scripting where the front desk, and it's beyond our scope today, we can do it another time if you like, the front desk doesn't simply get the patient scheduled and where they came from and get the insurance information. They've got scripting to promote the practice, the surgeons, and the implants. But, and here's the kick, if you have an ITC, the scripting also includes the ITC, and it goes like this. Grant, when you come in, you're going to meet Sally, our implant treatment coordinator, who is absolutely wonderful and everybody loves her. You set up the ITC in advance so that the patient has a positive expectation. Number two is the confirmation call. Again, I want to say to everybody, open your minds up, be open mindset, because it's a new world with new rules. And if you keep doing what you've always done, competition's going to whittle away at you. No question about it. So the confirmation call should be made by the ITC, not a confirmation text. I love confirmation texting for general practices, for third molars, for a biopsy, not for implants. Implants are still elective. Nobody has to have them. Maybe you could tell me I'm wrong, Grant, and I'm open to it, but I've never read about a patient that died from not getting an implant. It's not life and death. And, your earlier comment really struck me. What's the potential market for dental implants? And I'm going to tell the surgeons it's huge. We have not even scratched the surface. If you look at Clear Choice are practices that do millions of dollars a year. I know their numbers, but I'm not going to say them here. But they do huge production, all based on going directly to the public and convincing people to come in and get implants. These are people who didn't think to go to their dentist and get implants or didn't listen to their dentist. There's a huge market out there for dental implants of partially and fully edentulous patients. And by the way, scary. Wait 10 years with this fluoride situation, you're going to have a lot more because we're cutting back on fluoride in the water in areas, and that might grow. But having said that, for today, the ITC makes the confirmation call. She introduces herself to the implant patient or leaves a message. She tells the patient how much she's looking to meeting them. They already like her. I'm saying her, it could be a guy, but it's usually a female. They like her before they walk in the door. And when they come in, now they're coming to see a friend rather than, they come in, they sit down, they get called back, and that's the first time they meet the ITC. And what I'm showing here is highly practical information, but Levin Group does everything step by step by step, and you've got to have checklists. So next on the checklist is prepare the consult room. What should the consult room look like? It should be uncluttered. It should not be sterile. It's not a treatment room. It doesn't have to have infection control. What are the colors today? In interior design, which is not my strength, we go through different eras. The earth tone era. I mean, when I grew up, you might cut this podcast off right here after I tell you this. And my father was a dentist. He was my partner later. But we grew up with lime green shag carpeting in our living room, and that was stylish. That was a stylish thing. I used to joke that when shag went out of style, they could just mow it. But we had lime green shag carpeting, and it was like a cool thing back then. So what are the colors today? And by the way, I'm huge on models. Have models of implants, not just digital pictures, because when people can touch things, you're hitting two senses, touch and sight, not just one. I've been asking myself, how can we get smell into this? How can we get, the more senses, hearing into this, the more senses is good. So we prepare the consult room. And by the way, when a patient arrives, they're to be out of the reception room within 3 minutes. Now, a surgeon hearing this is going to say, no way, can't be done. I know as surgeons, I have many phone appointments, and when they don't answer, I just say, you're probably running behind. They call me back 5 minutes later, 8 minutes later, because that's the way surgery is. It's a lot harder to know exactly the minute you're going to be finished, but not for the ITC. They can run on time. There is no excuse not to run on time. Okay, but we'll come back to that. Then the next step after prepare the consult room is review new patients every morning. We encourage practices to have a daily meeting, 10 minutes long, quick agenda, what's happening today. And one of the questions is, who are the patients coming in for implant consult? Where are they coming from? You know that if Joe Smith referred a patient, they're probably going to accept treatment. And you know that if Bill Jones referred a patient, they probably have no money and they referred them to you because they didn't know what else to do with them. So at least you get a sense, trying not to prejudge too much who the patients are. And then the last part of this section, and I'll stop for a moment, is you increase the implant referrals by communicating back to the referring office. So you need to take good personal notes about the patient when they are brought back to the consult room, which is our next section.
Excellent. Okay. So that kind of outlines the initial duties or responsibilities of the ITC
Right.
and how to first get that patient rolling and comfortable with the concept of doing implants. Is that right?
Absolutely. And we need to train them step by step. There's no school for ITCs out there. There are no books for ITCs out there. So we need to train them step by step. And I'm going to say one other thing to surgeons, because I respect your time. I want you to have the highest production you can. You know, Levin Group really was formed to create production and referrals. But once in a while, take a break and sit in and listen to your ITC. I bet the surgeons listening to this that have ITCs have not sat in on an ITC consult in months or years, probably years. And it makes good sense. And it's surgeons, if you think you're better at it than your ITC, you do a few consults and let them listen to you. We're in our training program, we will be teaching them script by script what to say. But over time, Grant, we all falter. I every Saturday my video pearls of the week come out from our. During the week, people get our tip of the day, and on Saturday they get our pearls. And I watch the pearls every Saturday. And there are occasionally Saturdays where I'm looking at the 3-minute pearl video pearl of the week, and I'm going like this: did I actually say that? So I can watch myself objectively because I'm being filmed, so to speak, videoed. Once in a while, surgeons sit in with your ITC and see what they're saying, and listen to what the patients are saying. Are they worried about money? Are they worried about pain? Did they find something on the internet? Are they wondering if you're qualified? What needs to change in the scripting to really make this work the right way? Really, really good questions.
I like that. This could be straight off the topic, so bring me back in if it is. But I feel like this is a weekly occurrence where a patient who's been worked up for an implant sees me, and once I start, conversing with them, I realize they are so confused about what an implant is, what the term implant means, how the timing, I feel like we just start running through things. Oh, well, you could get an implant or a bridge and this, that, the other. And like half the patients don't even know what that means, what a bridge is, what an implant is. And so I think it would be so helpful to have an ITC like laying all these ground rules and terminology and
Yeah.
models, because there is so much confusion, even with young people who've seen commercials and all this stuff.
Oh, I couldn't agree more. But I'm going to consult to you now, Grant, which is, here's the problem. You're starting at step two. Without thinking about it, you're saying implant as if they know what it is. Not everybody researches the internet first, which is probably a good thing. And the ITC always starts by explaining what an implant is. We don't spend lots of clinical time because that's not what they want to know. But yeah, we don't use terms like bridge without showing them a model. We don't use that's why I love models. This is what an implant is. This is the crown that goes on top of it. This is the bridge or denture that could go on top of it. no matter how educated the patient is, we always start with a fundamental basic overview with a model. Models are very important to have and show because
Yeah.
when people look at digital photos, and please everybody, do not show them lots of implants being placed. My God, you'll scare them to death. Implant surgery is not all that bad, but it sounds bad when you describe it. We're going to take this, titanium, and they don't care what it's made out of. It could be made out of uranium for all they care. And they just want to know you're going to put something in my mouth that's better than what I had, that's going to look or feel like a tooth and make me really comfortable and last a long time. But they have to see it to understand, well, what exactly am I buying here? But they don't want the engineering or molecular specs on the implant.
Yeah. Do you have any recommendations as far as the wording? Because usually, I'll sit someone down and show them a picture or model and say, just so the implant we're talking about, when I say implant, I mean the post or the screw.
Mm-hmm.
And then when we talk about the white tooth part, that we call that the implant crown, because I feel like if you don't establish the wording there, you could just say to a patient, "Oh, we're going to do the implant today." And if you just gloss over that, they think you're putting in the whole thing, the crown, the implant, everything. They're walking out of there, and then when they walk out and they just fill the gap and there's just a post, some people are like, "What? I thought I was getting the tooth." So you got to kind of hold their hand and go step by step.
Well, and with the model, you show them the implant, and you say, "All right, in the surgery in our practice, we're going to put this implant into your mouth." Again, we don't talk about screwing it into bone until we get to that part. Into your mouth, it will be as good or better than the natural tooth you had. It will last for many, many years, if not your lifetime. And then your Dr. Smith will be putting a crown, and that's when you pick up the crown and show them the crown, the bridge, the denture that goes on top of it. Dr. Smith will be creating and placing a crown on top, or a bridge, or a denture. So the scripting should be clear, and we always remember that people hear what they want to hear. So you talk about it as a two-part process. Part one is in our office, and part two is back in Dr. Smith's office.
Got it.
Yeah.
Okay, so the ITC has done this workup. They've talked to the patient, sat him down in the consult room. Where do we go from there?
Okay, so I'm going to go back just a little bit because you've got it right. But let's start part two, responsibilities during the new patient visit. So the first thing is the ITC goes out to get the patient. She does not yell out into the reception room. She does three things. She smiles, she makes eye contact, and she shakes hands. Okay, don't just say, "Mrs. Smith, come back." I see this a lot, by the way. The door opens, the window opens, something opens. Not that you want a window, and somebody just yells, "Dr. Stucki, can you come back now?" And, Dr. Stucki. So,
Yeah.
it's like, "Oh, it's me." You go out. The front desk person tells you who the patient is for the consult, and you go out and you get them. Shake hands, smile, make eye contact. And then when you take them back, the first thing you do is called the Golden Five. You learn five personal things about the patient. You don't start with implants. You don't start by looking in the mouth. You don't whip out an x-ray. You get to know them at a personal level. And it's so easy. Just ask them a few questions. But the more personal you can be, the stronger the relationship. Right there might be one of the most important steps in the closing process. Then the next step is to take any necessary radiographs and explain why. Don't just shove them to the centralized pan or whatever you're going to use to get x-rays. You want to get those taken. And then you sit down with the patient and talk about implants. And that's the discussion you and I just had. You show them the models, you explain who does what, but talk benefits. Spend a lot of your time, and this is what we've built into our program, explaining the benefits, because most people don't want the gruesome details about implants. They want to know, what will it do for me? Will I feel better? Will I eat better? Will I look better? And part of it is asking them what interests you about implants. So they might not know much about it. But I've had many people said, "Well, I don't like the way I look," or my denture's slipping all over the place, or my general dentist said the following. Those are pretty good. The dangerous one is, well, I read on the internet, because that's where they get a lot of bad information, and I read reviews that people were this or that. And the answer to a bad review that someone read, not about your practices, well, I'm sure that could happen, but we have never had that happen in our practice. Or this is how we make sure that doesn't happen in our practice. So we call that the initial interview and obtaining the chief concern. And then the ITC should review the health history. Again, it'll make it faster for the surgeon when a surgeon comes in if they highlight. There's so few restrictions today in doing implants. One of our clients called recently. There was a problem with a patient because of some osteoporosis drugs they were taking. There was miscommunication. They were asking us, like, what do I tell the general dentist about this? There's so few contraindications for implants today. They just work really well. And you have to make that clear that, millions of these have now been done. They work extremely well. And then you explain the goal of treatment. We want you to be comfortable. We don't want your denture slipping around. We want you to have a beautiful smile when we are done. Of course, we place the implant, and Dr. Smith will place the crown or the bridge on the implant for you. So that's the first part of the ITC actual interaction with the patient. And then from there, we go into explaining how treatment takes place, because anything that the ITC can do takes pressure off the surgeon. Surgeons should be in and out of most implant consults in under 10 minutes. They're really there to simply review, finalize, and validate what the ITC said, unless it's an extremely complex case.
Okay. When you mentioned the Golden Five, just go back to that again. Was that questions you asked them, or what were you referring to there?
Well, the Golden Five, I'm sorry if I wasn't more clear, are the 5 personal things you learn about someone.
Okay.
Now, we know they're from the area. Typically, they don't come from 3,000 miles away. They might have a job in the area, or they have kids, or they, have certain hobbies or things they like. So it's really just getting to know them. Tell me.
Yeah.
A great question, doesn't sound like a question, is tell me a little bit about yourself, or what do you do in your life, or tell me about your family. And people love those kind of questions because it's personal. It makes them feel good. You might not like that if you sat down in a restaurant, but this is a very personal service we're about to engage in. And when you know 5 things about people, they're getting comfortable with you. They're starting to trust you, and trust is just such a critical word. And that's why the next step is the ITC has a script to talk about the practice, the doctor, the surgeon, and the technique. So the practice, it needs to be a nice looking practice. It needs to be aesthetic. It needs to be clean. It needs to be reasonably designed. If it was designed 20 years ago, get an interior designer in, upgrade the look of the office. If the office looks good, we can talk about the practice has been here for 5 years, 10 years. Dr. Smith's been here 20 years. He's done thousands of implant cases. They are almost all successful. And you are really going to enjoy meeting Dr. Smith and his or her personality. I can tell you, he really cares. Now, the best thing, Grant, is if you can find a staff member to put an implant in. So you... If nobody needs one, just take a tooth out of an assistant. But if you have a staff member that has an implant from the surgeon, that's the best. And in fact, Sally, our surgical assistant, has an implant that Dr. Smith, meaning the surgeon, placed. She's thrilled. So, and that's not a HIPAA violation, so to speak. So in that regard, you wanted the practice to look good, the surgeon to look good. And then if there's technique to talk about, if you've got any advanced technology, digital technology, robotics, we work all of that into the scripting. Really important. And we spent a lot of time analyzing how to get this into the process, because the promotion of the practice, the surgeon, and the technique is one of the most important aspects of the ITC consult.
Just backing up a little bit, I like the part where you were mentioning the importance of getting the chief concern of the patient, because I feel like it's all over the map sometimes, and it's important
Yeah.
to tailor the conversation toward that concern. Of course, some people they get an implant for looks, right? It's in the front tooth, or some people want
Mhm.
to chew, but then others, I feel like they come in and after like 10 minutes, I realize their chief concern is how much will it hurt because they had a neighbor and the neighbor's implant failed and it was the worst experience of their life. And it's like trying to tease all that out and tackle that concern. You've got to find ways to get there fairly quickly, or you could miss it.
Oh, absolutely. We have 5 questions that we go through with the patient. Not we don't ask these questions, but one of them is there a hot button? Is there one reason overriding, other than I lost a tooth and I should replace it, or the general dentist told me to come for a consult? We really focus if there's a hot button. What we teach the ITC is that's all you talk about after that. If someone wants to lose weight for their appearance, I'm using an analogy here, talk about the appearance. If they had a heart scare, then we talk about that. If they're worried about becoming diabetic, you talk about that. You appeal to what people care about. And that's
Mhm.
what makes oral surgery an individualized service, because everybody has a certain reason that they're there. And if they have one that's overriding, that's what we want to focus on. You express that really well, and I completely agree. And we teach them how to do that, because otherwise they go into this robotic mode of, okay, fine, there's the hot button, but now I got to go right through my scripting and I got to go right through my steps, even though that's not what the patient wants to hear. So we teach them how to shift within the consult in the best
Yeah.
interest of the patient and case acceptance.
Yep. Love that.
Yeah.
Okay.
Well, then there's some logistical things that I'm not going to spend any time on, like confirming insurance, getting informed consent. These are just checklist items that are routine and not important. But the ITC also takes some pressure off the front desk. They handle these administrative areas as well, which means the front desk can spend more time on positive production activities. Meanwhile, the surgeon's not involved in any of this. And then the surgeon comes in. And we are also going to train the surgeons in this program how to come in the consult room, meet the patient, comment on some personal things. Implant exams in the mouth aren't all that difficult. I joke, the diagnosis is they're missing a tooth or teeth. So, yeah, you've got to look at the radiographs, you've got to look at the teeth. Most cases aren't very complicated, even if it's 2, 3, or 4 implants. If it is, then you've got to go further. You've got to decide bone grafting, ridge augmentation, those sort of things. But keep it simple. Everything for the patient is simple. If it's bone, we're building bone so the implant has a place where we can place it so it stays, for many, many years, if not forever. And the surgeon does the exam, and then the number one job is confirm and validate that the implant case not can be done. We're way past that. There aren't that many that can't be done. That the implant case will be very successful, and use words like success.
Yeah.
Don't be afraid to use them. I once had a surgeon say, "Well, I got to be careful what I say, because if it doesn't work out, they can sue me." And my comment was, it doesn't matter what you say. If they're going to sue you, they're going to sue you anyway. So as long as you're being, forthright and honest and transparent, be as positive as you can. I can tell everyone listening, I love implants. I think implants and orthodontics might be the 2 biggest quality of life enhancements we can ever offer a patient. I mean, I love implants, and because I come from a few years before they started, and once they came out, I said, "My gosh, this is one of the greatest things we could ever have." That and composite, white fillings in the front of the mouth instead of gold or silver. What incredible advancements in the 1980s. So I love implants. I love talking about implants. People call me in Baltimore, after a consult sometimes from their dentist, I don't practice anymore, to ask me if they should get an implant. They call me for a second opinion. And I love telling them, why would you not do it? What other body part can you replace with as high a success rate and as little healing as getting, dental implants? And by the way, you're going to use them all day long every time you eat or talk. So, be enthusiastic, be upbeat, confirm. And then all the surgeon does after that is ask the patient, do you have any other questions? Because by the time they've gone through the ITC portion I described, step by step, and the surgeon portion I've described, most patients are ready to say yes to implants. They're just and then there's the one last part, money. I have a saying, in the end, it always comes down to money. But I have another saying, it doesn't matter how much it costs, it's how they have to pay for it. With our care credits today or other patient financing companies, we can make implants more affordable for almost everybody. Lower fees can be interest free, higher fees can be loans. And we are going to train the ITCs at the beginning to let the patient know, by the way, we have wonderful financial options that I will go over with you at the end. And they say anyone can afford dental implants today. You take all that anxiety off the table, and then you bring it back at the end when they say they've decided they want them, and now you show them how they can afford them. They can buy cash, check, credit card, patient financing.
Yeah. Yeah, for sure. And I feel like it seems, I don't know about the percentages, but it seems like the vast majority, at least in our practice, they can afford an implant, but we have to set it up and put the right value, because if they understand how valuable they are, how great it will be for their life, then usually there's not much hesitating with the finances. But
Mhm.
if we haven't done a great job and they're not sure, and maybe we've put more time on the fact that it takes a long time and they can get infected and they could fail, then they're more doubtful. I don't know, there's a balance
Yeah.
there, but being enthusiastic, I think, is a good term to use.
It is, and again, I'll go back to what I said earlier and talking about success all the way through. Yes, there can be infection. Yes, but there's also an answer to failure. And one of the things we train the ITC to tell them is, you know, there's a small percentage where the implant does not take or does not work. Usually it's very early in the implant
Mhm.
process. And we will replace any implant at no cost. And the second time, it almost always works extremely well. Now,
Yeah.
Mrs. Jones, I will tell you, you're an excellent candidate for implants, and we don't expect that to happen. So
Right.
you reassure them. Now, there's one last section here that nobody's going to think of, but we have put it into our training. And remember, that our work is to get more implant referrals, but the ITC portion is we want to have them accept implants. So
Mhm.
the ITC sends a thank you note or email to every patient the next morning. The email is about how nice it was to meet them. It's very short, but it was great to meet you. I'm delighted to have the conversation about implants. You're an excellent candidate. And if you have any questions, and what do I say? Give them your cell phone, because an ITC is basically a salesperson. Now I'm ready to say that. They sell implants. That's the only job description. Sell implants. And if I'm in sales and you have a question that leads me to a sale, you can have my cell phone. So give them your cell phones. I can't say you have to, because that, there's after hours and all. But if a patient is interested in implants and has a question, I want to answer it as quickly as possible. The ITC also sends a email or text, and it depends on the office. We're going to do this case by case to the referring doctor to let them know the consult took place, the patient's an excellent candidate for implants, the patient accepted treatment, or the patient is going to get back with their decision in the next few days. But we want to reach out and touch the referring doctors, thank them for the referral, and reiterate, please let us know if there's anything we can do to make your referral, to make referring to our practice more convenient. And that also gets reemphasized by the PRC, the marketing person, who's a huge part of our program when she's working with the referring offices. And then there's more. Because not every patient says yes right
Yeah.
away. Some people want to check with their spouse, some people want to check their work schedule, some people want to check their bank accounts. So we have a follow-up program where you call the patient, not text, you call them 1 week later. And if you have to leave a voicemail, we've got a script for that. Mrs. Jones, it was wonderful to meet you. I wanted to follow up with you to see if you have any questions or I can be of any help. And we actually make 2 phone calls 1 week later and 3 weeks later with the patient. And Grant, I can tell you from testing and experience, it's amazing how many times you reach a patient and they want to schedule. They just hadn't gotten around to calling you. But the longer you go with them not making a decision, the more likely that decision will be negative just because they lose their motivation and they get busy with other things. So,
Yeah.
and then lastly, for the super advanced, super motivated, this is not required, ITC is giving them a call after surgery as their liaison just to say, hi, I know you had surgery. I heard it went great. And I thought I'd just see how you're doing. Now, surgeons can also make that call. But if surgeons don't want to make calls to patients, then ITCs are great to do that. And this is a skeleton overview of a very detailed process. I warn people, it sounds like I've just given you a lot, and I have, but once you practice it, by the 20th, 25th time you do it, it's as natural as walking and breathing. You just go right through your checklist, and you'll be amazed how your implant case acceptance will skyrocket. And that's also because we're going to get more referrals coming in. A surgeon might say, well, my patients are all accepting treatment right now. Well, that's great. What if we increase your referrals by 35, 40%? Will that change? And if it would change, we prevent a decrease in case acceptance by training the ITC properly. So I hope that gives everybody a really good overview of what this is all about.
Yeah, that was super helpful.
Yeah.
So it sounds like the ITC coordinates with the other offices, but it seems like the bulk of their time is with the patient and really, yeah, it's hard. We don't like to say really selling them or convincing the patient, but probably
Right.
just educating them. I mean, that's probably the most powerful tool to an
Yeah.
implant is just because they are so successful. They almost sell themselves if the patient understands how amazing an implant is.
Yeah, that's a really good point. I've used the word selling today because it makes the point. It's funny if a doctor calls and I'm the one they're talking to and they're interested in consulting, I always say to them, I just want you to be comfortable. I don't do sales. I just do great conversations. And I mean it. The key here is really having conversations with the patient. And by the way, things I didn't go into today, because you can only do so much, you want to get the patient talking. If the patient is not talking, asking questions, just sitting there, that's a bad sign, actually. So you want to include them in the conversation. If they don't ask a question, we have questions the ITC can ask for them. And the scripting is, so one question you might have or something you might like to know to make sure we're getting all our points across. This is not about hard selling. This is about only, and I like the word you used, educating the patient, but also a little bit motivating them, because I believe if they don't get the implant, it's their loss. And I think we have an
Yeah.
obligation to try to help them be motivated to do the best thing that they can.
Yeah. I pictured two different people educating someone, and someone is saying, "Oh, an implant is so successful. They're awesome. They help you chew better, you look better, you feel better. And here's all the reasons. Here's a model. Hold it, touch it. Here's some testimonials." That's education with a positive spin. And then there's someone else educating saying, well, just so you know, an implant could take up to 9 months and it could fail. And if it fails, it could be very painful and you could have infection and swelling. Like those are both educating, but one has a spin that's going to influence the patient in a certain way.
The way that's brilliant. The way I respond to that is talk positive. Now we have to tell the truth. We've got to tell them what could happen. I agree with that. We're doctors. We have that responsibility, but talk positive. Don't go out of your way to overemphasize the negative. I mean,
Mhm.
and that's people being defensive. And you know where I see that, Grant? After somebody gets sued a few times, they start like going out of their way. They're playing defense. I want to play
Yes.
offense with honesty, not defense, because a lot of those patients might get scared. They might not do it. I talked to a surgeon the other day who put an implant in on a 91-year-old. Guy's in great shape. He drives. He walks. We used to say things. It used to be unethical to do that. 30 years ago, 40 years ago, it was almost considered unethical to put implants in on someone that age because you were stealing their money and they didn't have that long to live.
Right.
That none of that is valid anymore. But the patient came in. Actually, I know the whole story, and said to the ITC, because we had trained this ITC. He said, "Honey, I'm quoting, you can skip all the stuff. I'm doing this." Because so it's and she was smart enough not to say, okay, and then go through all the script. She just said, great, let me just give you a few key points and we'll go over the fees. And it was a single tooth replacement. So it was, you can get the radiographs later. And she was smart enough to say, okay, I got the hot button. He's doing this. Let me not, she said to me, my job is not to mess this up. so, so, but but the ITC can be an incredible addition to a practice. Or if you have one, you owe her and you owe yourself the
Yeah.
highest level of training, and it frees up the surgeon a lot, which is great.
Yeah, I love it. What a powerful, concept, powerful position. So helpful to the surgeon and the patient to get a great treatment. I mean, this is great. So thank you for
Yeah.
describing that and running through that with us.
Great. Well, I look forward to future times with you.
Yes, and for you and our guests, hopefully in the next little while here, we're going to do episode with you where our guests have submitted questions, and if you're listening, you can submit questions yourself. But now that we've done so many episodes, we've gotten kind of a snowball of various questions that people have, and sounds like you would be fine answering some of our guest questions.
I will give you my best, but most of all, I think you and I will have a lot of fun,
Same.
which is great. All right. Thank you,
Excellent.
Grant. I'll see you soon.
Thanks so much.
Okay. Bye.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.